Good evening. Thank you very much for the opportunity to be able to speak with you about a very challenging topic, which is the current state of our psychiatric classification systems. And as you can see from our title, it's a real question of how to cope with the limitations of our current systems, which are descriptive. And the background basically is that despite the fact that psychiatric disorders are considered to be brain diseases, virtually nothing in the definitions in either the DSM-4 or the ICD-10 concerns the brain. None of the diagnostic criteria cover any kind of dysfunction in any kind of specific brain area. Instead, mental disorders represent superficial descriptions of how patients present. It's pretty much similar to the way medicine was at the turn of the 20th century, when fever was considered to be a disease. The problem is, and the problem with having a system that is based on the description of symptoms, is the treatment really depends upon an understanding of what the cause of the symptom is. So if you take something like fever, the treatment for fever due to an infection is very different from fever due to an autoimmune disease. However, in psychiatry, we're still back in that way of thinking where we just have the symptoms, and that really creates a number of problems. Now, the fact is that everybody's aware that the DSM-5 revision has been completed and will be published in May of 2013, and simultaneous with that, the ICD-11 revision is underway, and it's anticipated to be released in 2015. And this is actually the longest period of time between revisions of these documents. It will be close to 20 years since the last editions of both the DSM and the ICD. So it raises a question that after 20 years of having to use a descriptive system like the DSM and the ICD, is there any way to move beyond a superficial system and get to something that is closer to what we would like to have as a psychiatric classification? Now, let's just take a step back and just review what some of the goals are of a classification of mental disorders. And I think this is important to keep in mind because before I get too pessimistic about the limitations of the DSM and the ICD, I think it's also very important to see what the goals and the various goals of a classification system are, to be able to look at some of the strengths as well as the disadvantages of having a descriptive classification. So perhaps the most important function of a classification system is to facilitate communication among mental health professionals, between healthcare professionals and institutions when you submit bills and you submit paperwork indicating the types of psychiatric diagnoses of your patients, and between healthcare professionals and stakeholders. This allows us to communicate to our patients and their families about the nature of their psychiatric problems. Another goal of a classification of mental disorders is to employ reliable definitions of diagnostic constructs. So reliability has to do with the ability of two clinicians to agree on a diagnosis when they see the same patient. And without reliability, there can be no validity. This is a common statement. Reliability doesn't guarantee validity, but without reliability, you can't have validity. So it's really important for a mental classification to have a reasonable level of reliability. Another goal of the classification of mental disorders is to facilitate disease management by helping the clinician predict course of treatment response. And it's also another goal is to facilitate the identification and understanding of the underlying causal mechanisms of illness. Now, the ideal medical classification is based on knowledge of etiology and pathophysiology and disease processes. If you actually look at the International Classification of Diseases and you look at other chapters outside of psychiatry, you can see sort of what the ideal classification might look like. If you look at infectious diseases, for example, infectious diseases are classified according to the infectious agent. So you have a section for streptococcal infections, a section for tubercular infections. And this is obviously important because if you're treating infectious diseases, you need to know the infectious agent to be able to select treatment. But this is also true for cardiovascular diseases. If you look at the cardiovascular disease section of the ICD, they're classified according to pathophysiology. For example, a valvular disease, conduction defects, ischemic disease. Again, the different causes of the cardiac problem helps you decide what kind of treatment you have. Now, in psychiatry, this idea of basing a classification on etiology has strong historical roots. Some of the very earliest classification systems, for example, the system by Paracelsus from the 16th century, actually classified disorders based upon etiology. There was a category called Vicenia, which was for diseases caused by poisons. Lunacy was a category of diseases caused by the changing phases of the moon. And insanity was a term that was reserved for diseases that were felt to be hereditary. Now, the problem, of course, with these kinds of etiological classifications is we know that mental disorders are not caused by the phases of the moon. So to have a system based upon an etiological hypotheses that are not true, that's not very helpful at all. So it's obviously, and a more modern version of this is psychoanalytic and psychodynamic thinking has also had an impact on classification in the, certainly in the 40s and 50s. So the approach that we use currently, sort of in recognition of the fact that we don't understand the etiology of mental disorders, is to have a descriptive and a-theoretical approach. This was one of the big innovations of the DSM-3 when it was introduced in 1980. So the concept is that disorders are defined according to symptomatic presentations rather than according to unproven theories. And given that an important goal, in fact, one of the most important goals of a psychiatric classification system is to facilitate communication when you define disorders based upon, if you were to define disorders according to one theory, that would hinder its usability by clinicians who don't believe in that theory. So the beauty of a descriptive a-theoretical approach is it cuts across different belief systems with respect to the underlying causes of mental disorders. It allows clinicians from different perspectives to agree on how these how to do the classification because it's based upon how symptoms present rather than hypotheses about the cause. So the descriptive approach, now it turns out that the DSM and the ICD have some etiological elements. Yeah, the goal and the ideal, since we would like to be able to define diseases based on etiology, if the etiology is known, then that becomes the basis of classification. So both the DSM and ICD have a section called substance-related disorders. And by definition, all of the disorders in the substance-related disorder section are due to substances. So when etiology is recognized, then it is part of the system. However, since the vast majority of disorders we don't know the etiology, these must be descriptive. And this is not a new idea, even though DSM-3, when it introduced this widespread a-theoretical approach, made a huge impact on psychiatric classification. This actually harks back to the days of Emil Kraepelin. And in Kraepelin's textbook of psychiatry, in the introduction, he said that psychiatrists should avoid postulating etiologies to make a diagnosis and should stick with the course of illness, attend to the final state, and do follow-up studies where possible. So even back at the time of Kraepelin, there was a recognition that focusing on the description of the conditions and their course was better than basing a system on unproven theories. Now, what is, therefore, the basis of the descriptive system in the DSM? And it's the same system which is used in medicine, which is the idea of identifying a syndrome. So syndrome, and here are two definitions of the word syndrome from different medical dictionaries, is a syndrome is a group of signs and symptoms that occur together and characterize a particular abnormality. That's one definition. And another definition is the aggregate of symptoms and signs associated with any morbid process together constituting the picture of the disease. What's implicit in both those definitions is the idea that this collection of symptoms is caused by an underlying cause. So hiding under the syndrome is a specific etiology, if you could just figure what that etiology is about. And that was the cornerstone of DSM-3 when it introduced the syndromal approach. When major depressive episode was defined in the DSM-3 as a collection of symptoms that grouped together, lasted every day for at least 2 weeks, there was the belief that under that syndrome was a specific, one or more specific etiologies, and it was just a matter of time until we identified what those etiologies were. And I think that if we could go back in time to 1980 when DSM-3 was released and ask the people working on it, could you imagine 30 years from now, how many disorders do you think will know the etiology? I suspect that most people would have been fairly confident to assume that after 30 years of hard work, the cause of most mental disorders, at least the cause underlying the syndromes, would have been identified. And we all know that 30 years later, that has not been the case. So, now this descriptive system, this descriptive approach does have a number of strengths. And as I mentioned earlier, having a descriptive atheoretical definition allows mental health professionals from different orientations to utilize the same diagnostic system. Now this is a huge challenge because unlike I think other areas of medicine, partly because we don't have a good understanding of the causes of mental disorders, different clinicians from different backgrounds have very different theories about what causes the mental disorders, so what causes various mental disorders, and that could create chaos with respect to one clinician being able to communicate with another one. And again, having a descriptive approach that sidesteps the issue of etiology allows everyone to be able to communicate. And that meets the first goal of what a classification of mental disorders is about, which is to facilitate communication. The descriptive system, which was DSM-3 at least, had greatly improved reliability over ICD-9 and DSM-2, its predecessors, and that was because of the introduction of operationalized criteria. It facilitated the explosion of research by providing standardized definitions that could be used across research settings, both in the United States and internationally. It stimulated drug development. Even though drug development has sort of tapered off in the last 10 years, when the DSM system first came out, there was an explosion in drug discovery and drug development, and that was largely facilitated by having very specific operationalized definitions. Another side effect of having the introduction of the DSM-3 in 1980 is something that people are not as aware of anymore because it's more of a sociological issue. At the time of the introduction of the DSM-3 in the United States in 1980, at least in the United States, psychiatry was under fire with respect to its legitimacy as a medical profession. There were two I don't say incidents, but two things going on in the United States which reflected the widespread skepticism about the whole concept of psychiatric diagnosis. One was a study in the United States published in the journal Science called the Rosenhan study. And this was a study in which a bunch of graduate students were instructed to go to various psychiatric hospitals in the United States. This was in the late 60s, early 70s, and say that they were hearing the word thud in their head, and then presented to the emergency room, and all of them were admitted, and many of them were admitted for several weeks. And then it was revealed that these people were just making it up, and it was published in the journal Science, and it basically looked like psychiatry couldn't distinguish between real mental illness and somebody making pretend they had just one symptom, and it raised a whole question about the legitimacy of psychiatric diagnosis. There was also a book that had come out at the time called The Myth of Mental Illness by Thomas Szasz, which which raised questions about whether mental illness existed at all, or whether it was just a social construct that was used to control people who were considered to be deviant from society's standards. So this was the atmosphere during which the DSM came out. So when the DSM did come out, having a system of very specific disorders with very specific criteria made the DSM look like the rest of medicine. It gave a sense that psychiatry and that psychiatric professionals worked the way other doctors work. They had lists of symptoms, so there was a very positive benefit to the field at the time of the introduction of the DSM-3. It also improves patient education about disorders. It demystifies the diagnostic process. You also have to remember that at the time of the introduction of the DSM, at least in the United States, and I believe also in Europe, psychoanalytic psychotherapy and theories were the main point of diagnosis, and most patients had no idea what was wrong with them. They couldn't, if you said what was wrong with you, what did your doctor say, the patients would have no idea. Nowadays, with the DSM available in bookstores around the United States and around the world, patients are familiar with the terminology, and they know what a panic attack is, and they know what major depression is, and they feel that they at least have a handle on at least what the doctors think that they have and what their options for treatment are. Now, those are the positives in the current approach, which I think are important, but there are unfortunately more negatives than positives. The big problem and I think the big frustration in using the DSM and the ICD system is that descriptive diagnoses have no explanatory power regarding etiology, pathophysiology, or underlying mechanisms. And this is in contrast, of course, to infectious diseases and cardiac diagnoses in which the etiology and pathophysiology is sort of embedded into the diagnostic system itself. They're basically simply statements of presenting symptoms. And there's the corollary of this, and this is a big problem in the United States in particular, is the problem that we call reification, which is the idea of taking the diagnoses in the DSM and acting as if they were from the Bible, that they were come down from God, or these are real entities that have a basis as diseases. And you see this very commonly. You'll see a doctor or a psychiatric resident saying, Mr. Jones has major depressive disorder. I'm sure you've heard that phrase, patient X has this illness. And it's used in the same way as if you said, Mr. Jones has diabetes. Now the difference is when you say Mr. Jones has diabetes, you're actually making a statement about what's actually wrong with that person, that person has insulin resistance, and because of the insulin resistance, their blood glucose is elevated, and because of that, they're at risk for other illnesses. When you say that Mr. Jones has major depressive disorder, all you're saying is Mr. Jones has a pattern of symptoms in which he is depressed most of the day, nearly every day for at least 2 weeks, and there are at least 5 out of 9 other symptoms, and that's it. That's all you're saying. You're not saying anything about what the cause is, about what the context is in which it occurred, but what you might want to do about it. There's virtually nothing there other than the description. But people act as if major depressive disorder and schizophrenia and all the other disorders that are in the DSM and the ICD are actual diseases. And now this next problem, which I think is what, as I was sort of alluding to earlier, is that despite hopes that etiological explanations of syndromes would eventually emerge, despite a 30-year search, not a single underlying etiopathological process has been discovered corresponding to a DSM or ICD syndrome, which is a very sobering idea that our categories have been so elusive to be able to discover the etiology. And with the exception of sleep disorders, in which sleep lab findings are part of the diagnosis, there's not a single laboratory test that's useful in making a DSM or ICD diagnosis. Another problem with the current system is that treatment selection and its utility for treatment selection is minimal as well. It turns out that, and again, I assume everybody in the audience is familiar with this and probably as frustrated about this fact as I am, is that most DSM and ICD disorders have multiple, at least partially effective treatments. So you take the category major depressive disorder. If that category had one treatment that you knew always to use, then that would be very valuable to use the label major depressive disorder. But in fact, when you say this person has major depressive disorder, there's a wide range of treatments that might be effective. Different kinds of psychotherapy, various types of antidepressants, and then medications which aren't even antidepressants, like the second generation antipsychotics, ECT, deep brain stimulation. So the relationship between a diagnosis and the treatment is very, very loose. And the opposite's true. The relationship between treatment and diagnosis is very loose. If you take something like the SSRIs are effective for a large number of categories in the DSM and the ICD. Major depressive disorder, dysthymic disorder, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder, premenstrual dysphoric disorder, trichotillomania. And you can see these categories aren't even confined to one section of the DSM or the ICD. They're spread out all over. So you can see that there's a problem in the mapping of the descriptive system to whatever the underlying mechanism is, because presumably treatment is more closely connected to the underlying mechanism. Another problem with the current descriptive system that we all have to struggle with as clinicians is the issue of diagnostic comorbidity. And diagnostic comorbidity is the rule. Most patients, if you do a very thorough evaluation, meet criteria for 2 or more DSM or ICD disorders. And this is completely, largely artifactual. Ideally, when the term comorbidity was coined by a physician named Alvin Feinstein in the early 70s, and it was used to refer to an individual patient having 2 or more disorders. Somebody might have diabetes and heart disease. Even though they're connected and one may be a risk factor to the other, they are considered to be separate, distinct conditions with different pathophysiologies. The typical patient with with panic disorder and generalized anxiety disorder and major depressive disorder, even though it looks like they have 3 diseases according to the DSM, I think most of us understand they have one illness that has different facets to it. So this is very misleading, and it's largely an artifact of the fact that the DSM and the ICD have 200 or more disorders. When you have a system with multiple disorders that are defined very narrowly, and you have a patient with a very complicated presentation, it's not a big surprise that you'll end up picking up a number of different categories. And then the last point, which I think is another thing I assume most people are familiar with, is that the specific diagnostic categories in the DSM and the ICD often don't conform to clinical realities. Many, and for some sections of the DSM and the ICD, most patients don't meet criteria for any of the disorders. They end up having the unspecified category. And again, that's because the rigidity of these descriptive categories don't actually conform with what happens in nature. The other 2 other problems are the categorical approach overemphasizes the boundaries between disorders. And then the last point, which I'm going to get to at the end about one possible solution, is a point that when you look at it right away, it raises a lot of interesting questions, which is it's possible that the reason that we haven't discovered a single etiology for a syndrome is because the syndromes themselves are invalid, that they're so far removed from actual biological reality that a research program that uses these categories may be unable to find the causes because we're using the wrong categories. So that is a real big problem, and if we want to move ahead, we have to come up with possible alternative approaches, and I'll be covering that at the end of my talk. So, looking to DSM-5 and ICD-11, both of which are coming out now. When DSM-5 started out in 1999, they're largely due to the frustration with all of the points I've just made. There was a hope that it may be time for the DSM to move past the descriptive approach into a more etiological approach. In order to help that along, the DSM-5 process started with the development of a research agenda, and that research agenda was developed between 1999 and 2002, and the explicit goal of this research agenda was to transcend the limitations of the current DSM paradigm and to encourage research that goes beyond our current ways of thinking. I think that it was understood that there needs to be more research that has more creative in order to allow a transition away from the descriptive approach. So in that regard, 6 white papers were developed, and this research agenda the aim was to stimulate research, though even at the time it was understood that this was a long-term research agenda, and the odds that any of this thing in the research agenda would have an impact on DSM-5 was probably limited. And this was followed up again in the DSM-5 process, as well as the beginning of the ICD-11 process, with 11 research planning conferences. And in the conferences, they covered different diagnostic topics, and part of what they looked at was whether or not it was possible to include biological markers into any of the disorders. So what's happened, bringing us up to the current time, is despite hopes for the incorporation of etiological or pathophysiological aspects into disorder definitions, it was concluded, and it's probably pretty obvious to most of us who've been following the research, there's really been insufficient research progress to allow for any kind of meaningful transition from a descriptive classification to something that's more etiologically based. Now, however, it's not completely bad news. There is some incorporation of some of the research about the underlying causes in the DSM and the ICD. And its biggest change, it's in that direction, is the disorder groupings in both the DSM-5 and the ICD-11 have been reorganized to try to group disorders together based on what is known with respect to some of the underlying aspects of the different disorders. Other changes in the DSM-5 that reflect at least some movement in this direction is in the inclusion of biological markers in the descriptive text, and the actual inclusion of biomarkers for a couple of disorders. In particular, narcolepsy and some of the dementias actually have biological tests as part of the diagnostic criteria. But those, interestingly, are not typical psychiatric disorders. They're really almost neurological disorders. So I just want to go over quickly what the new DSM-5 and ICD-11, what's called the metastructure, that's the term that they're using for how the disorders are organized. Now, looking at the way the disorders are organized now, if you look at the DSM-4 and the ICD-10, the diagnostic classes are mostly grouped together based upon shared symptom presentation. So the DSM has a large section called anxiety disorders that includes obsessive compulsive disorder and post-traumatic stress disorder, panic disorder, and generalized anxiety disorder. All those disorders, what they have in common is the patients are anxious. So based upon that one feature, they're grouped together into the same section, even though I think many of us would question whether or not obsessive compulsive disorder and post-traumatic stress disorder are related in any significant way. So in DSM-5 and ICD-11, there's been a move to regroup the disorders, and this was made possible based upon common underlying factors, like the internalizing versus externalizing factors that have emerged from factor analysis. Now, this is made possible partly because ICD-11 is, the new coding system in ICD-11 is no longer stuck with only 10 major groupings. They're moving past the decimal system into a more of an alphanumeric system. So you can have up to 24 different subgroupings within the mental disorder section. So the ICD and the DSM are taking advantage of that and having many more basic diagnostic groupings based upon common factors. So for example, this is the new groupings of the disorders in the DSM and the ICD. It starts out with neurodevelopmental disorders. The common factor there is development, that they have their onset during the developmental period. There's a section called schizophrenia spectrum and other psychotic disorders. And the concept there is that some of the disorders like schizophrenia, schizoaffective disorder, and schizotypal disorder share genetic risk. Right next to that is bipolar and related disorders. Those two disorders live together now because bipolar disorder and schizophrenia, there's evidence that they share some genetic risk. Bipolar disorders have been separated from depressive disorders because bipolar disorders have a different genetic risk than depressive disorders. Then right after that are the anxiety disorders, and anxiety lives right next to depression because anxiety and depression share some common underlying factors like the internalizing factor. Then obsessive compulsive and related disorders is now its own section and groups together a number of disorders that have this repetitive compulsive behavior that presumably has a common underlying etiology. Trauma and stress-related disorders have been broken out. All of these disorders have in common trauma or stress as an etiological factor. Then dissociative disorders have been broken out, and it lives right next to trauma disorders because dissociation is often associated with trauma. And then we have a group of disorders that covers somatic symptoms. Somatic symptom disorder, feeding disorder, elimination disorders, sleep-wake disorder, and sexual dysfunction are all listed one after another, each one focusing on somatic symptoms. Then gender dysphoria, which used to be known as gender identity disorder, has been split out of the sexual disorder section because it's now understood, or it's always been understood, but now it's being highlighted that gender dysphoria has nothing to do with sexuality. It's really about gender. The next grouping, disruptive impulse control and conduct disorders, represents the idea that these disorders share an externalizing factor, that they're very commonly comorbid, and it reflects a certain expression of externalizing behavior. Following that is substance use disorders, which also share this externalizing factor. And what's been moved into the substance section is behavioral addictions, under the idea that it's likely that behavioral addictions like gambling shares underlying factors with the substance use disorders. And then lastly, we have neurocognitive disorders, personality disorders, and then paraphilias. Paraphilias being at the end because they're considered to be like personality disorders, often lifelong with a very early onset. So now, given the fact that we have this difficulty with the limitations of the categorical approach, what are the implications of living with a system? Since we're going to have a descriptive system for the next 10 or 20 years, what do we do about that? Well, one of the sort of my take-home message is that since we can't really move beyond the descriptive system, and since the descriptive approach is still very, very useful, I think the way to go is to try to take the descriptive approach and improve its clinical utility. Since clinicians do have to use this every day to help take care of patients, anything that can be done to make it easier to use. And explicitly in the ICD-11 revision, clinical utility is the #1 priority. And looking ahead to ICD-11, one of the plans is to come up with simplified diagnostic guidelines that emphasize the essential features for all of the disorders in a simplified way to make them easier to apply. And then the next point, since I think people do take the categories of the descriptive approach too seriously, another important sort of strategy that should be taken moving forward is that people should try to spread the message that these categories are simply diagnostic constructs that help people communicate, that they're not real diseases. I think it's the idea that these are, or the belief that these are real diseases, which causes a lot of the misuse of the DSM and the ICD system. Now, what to do about the future? So as we're waiting around for some paradigm shift, what could be done? And I think there does need to be some work to lay the groundwork for the eventual development of a new ideologically based system. And the problem is, as I was mentioning earlier, it's possible that the DSM and ICD categories are actually inhibiting research. And it's possible that that there are biological findings out there, but they're being obscured by the fact that we're using the wrong categories. So what do we do about this? So the proposal, which is actually being implemented now by the National Institutes of Mental Health in the United States, it is the development of an alternative, completely research-based system that's based on neurobiology, and that system is called RDoC. And it's basically, I call this a neuroscience-based finer criteria, which is setting up a new system of communication for researchers to allow them to think along the same lines and developing new studies to help elucidate the neurocircuitry base of the mental disorders. And this project is called RDoC, Research Domain Criteria. It's a research framework. It's not a classification system. It's simply a way of getting all of the researchers who are doing this kind of work to be using the same system and designing studies in the same way. And the whole idea is that you're supposed to, they've defined constructs with multiple levels of analysis that are dimensional. And let me show you what this is, what it looks like. They've created a matrix, the RDoC matrix, and this is what it looks like. If you, so there's not really a system with criteria. The whole essence of the RDoC approach is the development of this matrix. So if you look along the left-hand side, there are various constructs. Like the very first construct is fear extinction. Fear extinction is an idea that organisms, when they are exposed to a stimulus, can become, will exhibit fear, and over time that fear will extinguish. That has been shown to be associated with a certain piece of circuitry. So the whole idea of the RDoC approach is to base the system on neurocircuitry. So every single row in this table represents a different identified neurocircuit. The term on the left-hand side is the sort of psychological manifestation. So we have things like fear, we have aggression, we have reward seeking, we have attention, perception. These are not symptoms per se, but these are domains of functioning which are involved in psychiatric disorders. And the different rows and columns here basically say that for each circuit, where the NIMH is trying to encourage researchers to collect information on the different levels that go with that circuit. So if you look at the first line, which is fear extinction, each of the different units of analysis is to encourage researchers to identify the genes underlying that circuit, the molecules that are created by those genes, the cells in the circuits themselves, the behavior associated with that circuit, and then to use self-report measures. So it's a completely different approach that is completely based on neurocircuitry. As you can see, this is so far afield from what's currently being done in the DSM and the ICD. And this could not be used clinically. Let me move ahead here. So the idea here, and one of the big questions, is whether this will ultimately alter practice is really unknown. This is a long-term project that could take 10 or 20 years before any results come from it, but it's a completely different approach that is only vaguely related to the DSM and the ICD. The connection between the DSM and the ICD is when the different circuits were selected for the matrix, they picked circuits that are known to be associated with DSM disorders. So like fear is obviously associated with anxiety disorders. So that was one of the circuits that's picked. And the hope is that these are the building blocks that will eventually allow a much deeper understanding of the descriptive approach that's in the DSM and the ICD. So I think for us as clinicians, I think we're going to continue to use the current system because they're very, very useful, but I think that this new approach, which will exist in parallel, hopefully at some point in the next 10 or 20 years, they'll converge and allow for an actual shift away from the descriptive approach to a more ideologically based approach that could be used by all clinicians. So I will stop here, and thank you very much for your attention.